My name is Bryan McIver. I work at the Moffitt Cancer Center and I'm an endocrine oncologist who works primarily with patients with thyroid nodules and especially thyroid cancer. One of the most important aspects of thyroid cancer management is to recognize that this is usually thought of best as a chronic disease. This disease is not something that's a one-shot done and you're finished. Instead, we're dealing with disease that has immediate needs for treatment with surgery. Often that surgery changes your hormonal status because it involves complete removal of the thyroid gland. And then it requires additional treatments with things like radioactive iodine, at least in some cases, and with thyroid hormone, which needs to be adjusted. And then beyond that, it requires long-term surveillance and monitoring to assess the possibility of recurrence. Because even with low-risk thyroid cancer involving lymph nodes, the chance of a future recurrence is anywhere from 5 to 15 or even 20%. So what that means is we're on a long-term journey. And that journey goes on not just for 1 or 2 or 5 years, the way we used to think about many types of cancer, but instead for the patient's entire lifetime, because this cancer is slow. And slow-growing cancer obviously is better than fast-growing cancer as far as your prognosis is concerned, but it does mean that the possibility of late recurrence does exist. So for all of those reasons, having a clear, open communication and an ongoing participation in care is fundamental to a patient's management and self-management of thyroid cancer. So good communication between the patient and their care team, their physician, but all the other members of the team is really fundamental to a patient's well-being. If I don't know that a patient is experiencing symptoms that are being impacted by our treatment of the thyroid cancer, then I can't step in to make a difference. And the most obvious and overt example of that would be the use of thyroid hormone. We use thyroid hormone as a form of chemosuppressive therapy for thyroid cancer. It's actually part of the treatment of the cancer. And in order to achieve that, we have to actually somewhat suppress or lower the TSH reading by giving slightly higher than average doses of thyroid hormone. That can cause symptoms. Just as any chemotherapy can cause symptoms, it wouldn't be surprising if suppressed TSH caused anxiety or sleep disruption, changes in energy, changes in appetite, changes in weight, changes in just general well-being. And so it's really critically important for me to understand what the patient is going through in order for me to fine-tune the dosing. Because if all I do is focus on the numbers, I can set the patient's numbers to exactly where they need to be, and we can have the cancer under great control, and yet the patient is absolutely miserable. And that's not a good outcome. Similarly, if that patient then is not really following through on the recommendations because they haven't been able to communicate to me in a way I can understand that we find the right compromise, then we're often in a position where the patient pretends to be doing what I'm asking them to do, but isn't actually doing what I ask them to do. And that's the worst of both worlds, because then I can't step in to help, and the patient isn't getting the kind of treatment they need. So an open communication where the patient is front and center in that interaction in the care team is critically important. The patient is in fact a true member of the care team, and there has to be open communication amongst all of the members of that team. So when somebody's just received a diagnosis of thyroid cancer, the decisions that get made in those first few days and weeks are absolutely critical to the long-term outcome of thyroid cancer. It's tempting to have a knee-jerk response to be pushed into making urgent decisions. It feels like a crisis. It feels like an emergency. And one of the things I try to emphasize whenever I can, I'm speaking to patients or potential patients, I try to emphasize that there's almost never an emergency with thyroid cancer. Whether we diagnosed it today or we diagnose it next week or next month is going to make almost no difference to your outcome. Whether we treat it with surgery today or next month or sometime in the spring is almost never going to make a difference to the outcome, especially when we're dealing with the common types of thyroid cancer like papillary and follicular thyroid cancer. So we've always got time. And we should always make sure that we're making decisions that are logical, sensible, and as far as possible devoid of the emotion that is such a chaotic part of that initial diagnosis. The big C word, the big cancer word, is a scary thing, and it messes with our brains, and we can't process and think straight. And so I see far too many patients, unfortunately, who have been panicked into rushing to a surgery and are operated on by a surgeon with limited experience of dealing with thyroid cancer, simply because they're convenient, close, and have availability. So given a choice, if I had a person and I could tell them, you will be diagnosed with thyroid cancer one day, I'd say, when you're diagnosed with thyroid cancer, take your time. Sit down with the surgeon or with the endocrinologist, whoever made the diagnosis, and ask them, how much of this disease do you see? How often do you treat patients with this disease? How many surgeries do you do on an annual basis? If the physician is not used to thyroid cancer, if they haven't seen a lot of it, if they do very few surgeries, less than 20 or 30 a year, those are warning signs that perhaps it's time to seek out more expertise. Because those individuals are not focused on thyroid cancer, they're not used to thyroid cancer, they will not be up to date with the current state of the art of managing thyroid cancer, which has changed dramatically in the last 10 years. And therefore you should be seeking another opinion at least, and maybe another physician to look after you. Sometimes, of course, when you ask physicians that kind of thing, if you ask a surgeon that, they get a little offended. You know, they're asking you, how dare you question my ability to do this surgery? Somebody who's that defensive probably is not the surgeon you want operating on you, or the endocrinologist you want treating you. So I think you should be willing to question, you should be willing to ask, and you should also be willing to seek a second opinion. I'm a great fan of second opinions. I love second opinions. And any patient who asks me whether I think they should have a second opinion, I will immediately say yes. Because I'm very confident that the information I'm giving is the right information based on my long experience of treating folks with thyroid cancer. If the second opinion agrees with me, then it builds the trust that I have from my patient. If the second opinion disagrees with me, they're wrong. And that's okay. I'm allowed to disagree with them too. I say that somewhat tongue-in-cheek, of course, because none of us has an absolute lock on the truth. But I'm never threatened by somebody else's opinion. There are areas of true disagreement amongst specialists in the field with equal experience and equal insight and knowledge. I think we should be clear about what those areas are. And typically they're areas where I've already had that discussion with the patient. But a second opinion is always a valuable exercise. I think the most important thing is to have your thoughts in order ahead of time. If you have a chance to sit down ahead of a doctor's appointment and write your questions down with some clarity, I think that goes a long way to organizing the discussion, so you don't forget to ask a question, and it definitely gets covered in the discussion. The second thing is to try as much as possible to actually not be threatening to the doctor. So there's something threatening about a patient coming in with a huge stack of Google printouts, questioning every little decision that gets made and going through all of these papers. It's actually quite fun to do that, but it's disconcerting because you know it's going to be time consuming, and many physicians don't have that time. So asking fewer questions that are much more critical to you, rather than every question that's ever occurred to you, I think is a sensible strategy. I really do think that the most important thing is to recognize it is a journey. That this is not simply come in, have a surgery, and move on with the rest of your life. A diagnosis of thyroid cancer is life-altering and impactful, and has consequences that will reverberate across years and decades through the entire rest of your life. So you have to get comfortable with the journey. You have to settle into a new normal. And that new normal doesn't need to be dramatically terrible. It's just going to be different. It's going to be different because you have to take medication. It's going to be different because you have to see a specialist. It's going to be different because you need scans and follow-up, and there's going to be uncertainty on that journey. And you may even hit some potholes in the road as you go along. The discovery of another lymph node involved in the cancer, or the discovery of thyroid globulin levels that are out of the range that we're aiming for. Those kind of things are going to have to be taken in stride at some level. But the most important message, I think, is to never panic about any of this stuff. Seek expert counsel and expert opinion, and make sure that the person who's looking after you is open to that communication and communicating with you clearly, because communication is a two-way process. You've got to be able to ask your questions, but I've got to be able to reach back out to you and explain what's going on in terms that you can fully understand and fully integrate into your understanding of the disease.